on Dr. SIRISH NELIVIGI. He is a solo practitioner, an excellent glaucoma surgeon, excellent phaco surgeon. He is going to talk on Audacity of Laxity. I don't know what it is.
Laxity is a zonular laxity, so how audacious they can be.
Okay.
So I am talking about two scenarios, where scenario one where you know that the subluxation and zonular laxity, oh, it's not running there, sorry. It's running here for me.
Audio
just project it here, please.
Anybody from audio?
Yeah. Okay. So it is about zonular laxity and how audacious they can be. I'm talking about two different scenarios. Scenario number one, where the zonular laxity is already pre-known, and before you start your surgery, you know that there is laxity of the zonules. Obviously, I'm talking about a scenario where this is along with glaucoma. So this makes the challenges difficult. Here in this scenario, of course, decision one will be whether if it is a long-standing chronic glaucoma, whether you want to add up glaucoma surgery on top of having challenges of doing a cataract surgery here or not. So you tend to be a bit more conservative in such situations. Obviously, the challenges of cataract surgery here will be itself quite a lot, and you would have to take care about how you make sure you need to get as big a excess as possible, whatever is reasonably allowed, and then CTR, if laxity is less than about 180 degree, you can do it. But as you see here, as you are placing the zonule itself, it can tear a little bit more zonules than what were there before. So in additional support, you can always place iris hooks with you can do it, just the CTR alone may not always be sufficient, because if you give a good traction on the other side, you'll be able to hang on to the bag much more easy. So here you always have a threat where you can end up hydrating the vitreous, and in the scenario of a glaucoma where you are hydrating the vitreous, it's going to be an even bigger difficulty, and such situations you may have more challenges coming up for you. When you are placing the intraocular lens, make sure you use one of the haptics have to be placed along the area where the zonular laxity has happened. This is how it is positioned there, and then after that the decision, if you this is scenario number two, where actually the trabeculectomy was started, but then when the rhexis was initiated, it was observed that there was a gross amount of zonular subluxation. So this was not known prior to the surgery. Since it was a brown cataract and a small pupil, and the amount of tilting of the nucleus was very, very huge, a conversion had to be done. So this was converted into a SICS, and it was observed that since the laxity of zonules was very severe, there was no practical way that phacoemulsification could be done. A large extension was done, and the nucleus was fished out. So here the priority will be to just make sure you don't have a drop and complicate your process further and make it a triple trouble. The question here is, would you want to go ahead with a trabeculectomy in such a scenario? The answer is yes, but there are challenges involved. Once you have a scenario like this, you have the vitreous which comes. Unless you do a very, very good vitrectomy, you have situations where you might end up with vitreous inside the ostium, which can actually negate the whole effort that you have been doing. And actually, you do need trabeculectomy happening here all the more. Though this was a pre-existing glaucoma patient and you wanted the glaucoma surgery for the raised IOP, but then when you have complications like this, you have another added risk factor, which is so increased inflammation and vitreous there, which can again increase the further risk of additional risk factors for glaucoma. So it is advisable that you go ahead with a trabeculectomy, though the chances of blockage can again be pretty high. As long as you make sure that the vitrectomy is done properly, and then maintain the post-operative status well, control the inflammation well, again you can reduce the risk factors of further elevation of intraocular pressure in such scenarios. if you take care of the right situations, pre-operative, intraoperative, and post-operative, you should be able to handle quite a lot of iatrogenic glaucomas and drug-induced glaucomas, inflammation-involved glaucomas, which can actually potentiate the complications during the surgery and before the surgery and after the surgery. Thank you so much.
Thank you, Dr. Sirish. So it's a wonderful demonstration of your surgical skills. The first case, I would have done it slightly differently. That is a case of subluxation where you could see the vitreous was protruding, no? Like could have injected this thing, IV, yeah, triamcinolone, and done a vitrectomy, and then you would have gone ahead with the capsulorhexis and capsular support with the capsule hooks. And you could have waited for some more time till you finish your case. If the bag is stable, you could have injected your CTR a little later. So I would have done that way. Dr. Santosh, what is your technique in this particular case?
I would also have done vitrectomy first, but otherwise it is just the same iris claw lens with this. Regarding trabeculectomy, the decision making has to be judicious, probably. Same setting trabeculectomy, or maybe you observe post-operatively how the patient behaves and then decide about trabeculectomy. What do you feel, Dr. Rajesh, about trabeculectomy in such situations?
Yeah, actually, that's what I was telling. That in all these cases, wherever you are in a borderline situation, and you are thinking that by removal of lens only, if we can have some reasonable control of intraocular pressure, maybe we can see in the post-op period we can.
Yeah, because that surgery we can always do in a subsequent stage. If we can manage pressures by using medicines, which are very good medicines are available, it's better to manage them medically rather than directly jumping to surgery. Because if there is also a chance of failure of trabeculectomies on long-term basis after 5 years, 7 years down the line. So I don't know, it's a point for thinking.
In the first case, the trab was the trab was not planned, it was a glaucoma surgery. In the second case, the trab was planned.
Exactly. You made a flap
Yeah. In the first case, you had done the flap and then started.
Planned there. It was a glaucoma
It was a plan,
case
you had planned it, so you did it. Yeah, correct.
So ultimately, in the first scenario, that is what eventually happened. We managed the glaucoma on a long term on medications. In the second case, the intraocular pressure was fairly okay. When it was managed fine, but then again when we have trabeculectomies done even like this during the course of surgery in the first sitting itself, the chance of failure of trabeculectomy is generally much higher than a routine trabeculectomy. So there are possibilities of again a retrab which may be necessitated over a period of time.
So is it better to delay trabeculectomy as
I think when you have done the flap, I think you have done most of the work there. Ostium is done. Yes. And moreover, when you do an incision as big as that, which is like SICS, that itself works like a wick there. And that itself is a big trabeculectomy.
Yeah, I guess it's the scenario based.
Just making a punch of another 1 mm larger punch there actually doesn't make too much of a difference. If you
you have to decide as per the scenario
correct,
at that time.
Yeah. Thank you, Dr. Sirish.
One acknowledgement here, the videos I thank Dr. Krishna Prasad for the videos actually.
Thank you, Dr. Sirish. So we have one more talk to go. Dr. Anant D. Dr. Anant, he is a senior cataract and refractive surgeon at Lotus Eye Hospital, Coimbatore. He is going to talk on dry eyes and cataract surgery.
So, good morning everyone, and thank you Sirish sir for including me in this topic. After listening to all surgical challenging cases, it's a cold case, medical case each and every day. All these cases you will see once in a week, but my topic, each and every patient, either you may be exaggerating the dry eye or you may be forgetting about the dry eye and doing the cataract surgery. So, we do perform the cataract surgery very successfully, but if at all, if dry eye is forgotten or if it is neglected or if it's exaggerated, the quality of life is affected to the patient keeps coming repeatedly to us, it can have a double-edged effect affecting our name and